So let's talk about the patient that you can't achieve your goals, right? You've spent 4.5 hours doing a very complex epicardial retrograde. You feel like you've just won the championship when you walk out, and then they're back in 2 weeks. You're sort of holding your breath a little bit, and you're like, so how do you feel? And then they come out with, well, I really kind of feel the same. So that sigh, I know that sigh. So what's your algorithm then? What do we do then?
Yeah, so that was sort of the impetus to get us involved in some of these clinical trials, because that is not a terribly uncommon scenario where you've done everything for a patient. You've maximized her meds. You've had a surgeon take a look at them. They've been turned down for surgery. You've done a rather elaborate percutaneous procedure on them that took hours to complete. Results are good. They come back to the clinic and they don't really feel any better at all. And sometimes they feel worse, unfortunately, because they've had some sort of a peri-procedural event on top of everything else. And now you really are kicking yourself because you're like, gosh, what are we going to do to help this patient turn the corner here? And that's where some of the clinical trials that we've gotten involved in come into play, and we can certainly get into that.
Well, here's where I want to introduce the concept of the coronary sinus reducer, which I know you're familiar with, because this is a new implementation of a relatively older technology. I think the coronary sinus reducer was first introduced in the early 2000s as a concept, and conceptually came back to a minimally invasive, the Beck surgical procedure back in the 50s. So there's actually a long history of it. So why don't you just summarize for the BackTable viewers and audience, what's a coronary sinus reducer?
Well, I guess it's probably helpful to describe the Beck procedure. So this is an operation described by a surgeon at University Hospitals of Cleveland in the 50s, where they would open the chest in patients with angina. This is before we had bypass surgery, and obviously no stents or angioplasty. They would open the chest, put a 3-millimeter stylet on the coronary sinus, and sew a stitch around the stylet, effectively reducing the diameter of the coronary sinus to 3 millimeters. And they described a remarkable reduction in angina in these patients. And this was a procedure that preceded any sort of revascularization options for patients. And it kind of went away because obviously bypass surgery came around. And then after that, all of the stuff that we do in the cath lab. It's only just sort of been resurrected in a percutaneous fashion in the 2000s and onwards, because we're at the point now, as we described earlier, that we have patients that have had all of these treatments and they're on all the meds, and yet they continue to have angina. And so it sort of resurrected this idea that, oh, okay, there's this procedure that was described back in the 50s that required surgery, but we can replicate that percutaneously. And the way that they do this is they've created an hourglass-shaped stent that is designed to fit in the coronary sinus. The waist of that stent is 3 millimeters, so it basically approximates what Dr. Beck was doing with his stitches. And the idea is that if you can deploy this in the coronary sinus, you can create a restriction of outflow from the coronary sinus, and the mechanism of how that should treat angina is still being explored and not entirely well understood. But there's some interesting evidence that's been presented in multiple papers, some of them in randomized clinical trials, to suggest that this may be an effective therapy for angina.
Yeah, so let's just talk about the evidence. I think the elephant in the room is the COSIRA trial, which was published in the New England Journal of Medicine. 104 patients who had exactly this type of refractory angina had evidence of ischemia, meaning there was actually a restriction in blood flow that could be documented through some modality, and they were considered to not have revascularization options. I think that's important, right? So this wasn't as simple as going in and just popping on a stent or getting a bypass. And 35% of the reducer patients improved by 2 CCS classes versus 15% of the sham controls, and their quality of life improved significantly. And this was the really sort of first, I would say, solid randomized evidence and proof of principle that this could actually work going back to Beck. And so that's really opened up this whole new era of potentially working in the coronary sinus, not only for obstructive refractory angina, but also for other things such as heart failure. And so tell us what about COSIRA-II and how we're moving forward in the field with this technology.
Yeah, so COSIRA-II is sort of the follow-up randomized clinical trial. Again, blinded, sham-controlled. The difference in this trial as compared with COSIRA-I is that the primary outcome is exercise treadmill time. So one of the big criticisms of COSIRA is that the primary outcome was really a physician interpretation of patient-reported symptoms, so the CCS classification. And obviously, there can be a lot of outside factors that can play into what a patient describes as their symptoms and what a physician interprets as the patient's symptoms in the clinic. So this is designed to be a little bit more objective in terms of determining what clinical benefit can we observe and measure in a reproducible way. So exercise treadmill time is sort of thought to be a better way of assessing the effectiveness and the efficacy of the device.
And I want to just take you back to the Beck procedure because, of course, they have their chests open, right?
Yeah.
And so one way to, move someone's state of mind is, sort of gate theory of pain. Hey, you have chest pain somewhere. Well, you had an operation, we cut your chest open, so now it's got to be better. Let's talk about the sham-controlled component of this and how important it is, specifically when your first outcome was subjective improvement of patient symptoms, but now also incorporating the primary endpoint of exercise tolerance time.
Yeah, I think that without a sham control, it's really, really hard to get beyond what the physical effect of the device is versus some of the outside influences of just having gone through a procedure are. There's just no other way to get that confounder out of there. And without taking that emotional part of it out, I don't know how we can really understand this, because a lot of angina and the burden that goes with it is emotional as well, as we've talked about, and it plays into this. And we have to have a way of looking at this very objectively so that we can be honest with our patients. And I think that the sham control is really the only way to do this. That's sort of been the bane of the existence of our CTO trials, is that the genie's kind of out of the bottle for CTO PCI, and it's very hard to do that kind of a trial at this point because no patient will accept it. These are patients that are in a unique situation where we've effectively exhausted all treatment options. So for better or worse, we have an audience that's willing to accept even this to see if they get better. And this is a way for us to be much more scientific about understanding what the device is actually doing.